Hello, everyone. It's live with CCO. It's episode 90. You know, we love to do our live with CCOs. That's because we take questions and topics that you have asked to have presented, kind of unpack them. And today, this is one that's extremely relevant for today. So if you're not watching this as a recording, and I know I can see all the people that are here alive, that there could be some changes because the topic that we are going to be covering is telehealth. And not just telehealth, we're all pretty well versed in telehealth as it is, but the changes after the PHE, the COVID-19 PHE. Uh, they've kind of extended a couple times, saying that no, we're gonna keep everything in place, and uh, that is that is still the case in part. Now, because you're watching this and we're going to keep this up and it's going to be available to you, there will be some changes after this if you're watching this at a later date. But as of the airtime, we're going to go over some of the specifics, but I'm not going to get real in depth for every area because it could change tomorrow. So, hi Carmen, how you doing? It's so great to see Carmen out in New York, and I see some other names popping up that look familiar. All right, so what is telehealth? It ultimately is the ability to see patients via the telephone or video, audio, video. Uh, Keep in mind that they are not the same. If some things, some services are approved for video visits only, and others are acceptable for telephone. And I know that when I was working with Baylor Scott and White, when that was right before I started with them before the pandemic, and they had all of their providers put in a statement regarding that this is a telehealth video visit, and then had a blurb that was obviously approved across the board. And as you know, Baylor Scott and White is a significant health system, and probably the same thing occurred. Well, I know it has occurred because I've seen the documentation across the United States with other entities. But it's very important in that statement that they distinguished if it was a video visit or if it was a telephone visit. So that's the first thing you need to keep in mind when you're talking about telehealth. Telehealth is broad and narrowed down. Is it a video visit or is it a telephone visit? And then let's add something else to that. What if it's a video visit? It starts out as a video visit, and you're into the encounter, and something happens, and they convert to a telephone visit, and they say, okay, well, let me just give you a call, or you give this number a call, and then we connect and we finish out the visit. So how does that work? Well, there is nuances about how that works, and uh, best advice for you to tell your providers or providers to know is that you need to document what occurred. This is a video visit for telehealth. And then if at any time it's converted to a telephone visit, then it can, be documented due to technical difficulties and stuff. Stephanie Sanchez, she has made a great question. She said, if a provider is a risk adjustment and has no office location and they perform mainly telehealth video visits and some home visits, what would be the appropriate E&M for the telehealth video visit, since technically they don't have a clinic? They have to have a clinic. They have to have a home base. And Stephanie, I don't have the code at the tip of my fingers right now, but if you want to send me a note, I'll get the research for you and tell you what that code is, or if anybody else that is here uh, wants to provide that. But off the top of my head, I'm not able to just spew that out, and it's not in the information that I know I'm providing tonight. Really good question. Now, I can tell you for risk adjustment, telehealth does not work. It is not approved. It's the criteria for risk adjustment, face-to-face visit from an approved CMS provider, or during the COVID-19 PHE, you were able to use video visits, and with the knowledge that that could be pulled away at any time. Let's go ahead and get into this, and let's talk about a few of the things that you need to be aware of. One of the things that I want to tell you, and this might be helpful to you, Stephanie, is I'm going to show you the information, and then in the resources that I've saved at the end of the slide deck, you're going to be able to jump into those links. Okay, and that is very, very important, because all of this information is there, and you want to have those links saved so that you can go grab the information, have it at your fingertips whenever you need to. Marshawn said for RA, it has to be a video and audio. Correct. It has to be a video visit, and that means audio, video, audio. Just on the telephone are any codes or diagnoses captured during a telephone encounter is not accepted for risk adjustment. Well, if you haven't heard of the GAO, the link is going to be in the resource, but they made a couple statements that I thought was very pertinent. And they said, uh, even before we had the pandemic, we had telehealth. And I got to sit in a lecture once that was really interesting. This was several years ago, pre-pandemic. And it was a director, I think she was the director of a health system, and they specialized in the working for the state of Texas, doing telehealth visits for the incarcerated. So it was the state penitentiary system for the state of Texas, and I think it was other prisons within, not just the state penitentiary, and I may not remember that exactly, but the state facility itself was pretty high tech. And they were on the cusp of using telehealth. And what they did is they had nurses. They maybe had nurse practitioners and PAs, but I know they had the registered nurses would um, have the provider on the other end of the screen, and they would perform any service or exam portion that the provider wanted. And even if the provider wanted to look in the patient's ears, they could do that. But then the nurse would say, I'm looking in the patient's ears, and their tympanic membranes are clear, da 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 da, and they could actually hear the heartbeat, they could connect it, but also the clinician was able to relay that. They could do EKGs, they could do a lot of really interesting things at that time. And this was, gosh, I don't know. I was thinking I was still in Missouri at that time when I was at that lecture. But they were very forward thinkers, the state of Texas, using telehealth. So we had telehealth prior to the pandemic, and most of you probably are fully aware of that. However, they really didn't use it that much. Now, it was available, but it was like, am I going to get paid? Am I going to get paid enough? It's not really worth my time to invest the training for my staff, for me to do this, et cetera, et cetera. Is the way I see it. But before the pandemic, the GAO had stated that Medicaid beneficiaries, they had flexibility to use telehealth in most states. And that's also probably why the state of Texas at that time was using this. It would have been a state funded health system for the penal system. And then Medicare beneficiaries did not have that option. Uh, so if you were a Medicaid or Medicare patient, the provider wouldn't have gotten paid if they had done a telehealth visit. But if you were a Medicaid patient, there were several states that you could have gotten paid. Now, pre-pandemic, I had telehealth visits. um, and one was for like an asthma condition that I had, and another time I was having migraines. Long story, but I have chronic; it never goes away, and my medicine wasn't kind of doing it anymore. So had a telehealth visit with my nurse practitioner and decided to, change up my medication. Again, this was pre pandemic, and my insurance paid for that. Uh, but it might not have been an option if, one, my payer didn't offer that, and if the clinic system that I used wasn't set up for it, but they were. Now, let's go on into what it says about uh, by law, Medicare only paid for telehealth services under limited circumstances. And the number one thing is, you know, a patient isn't, it's not easy for the patient to get in because of the location of where they live. A lot of rural stuff, they may have made exceptions and stuff. But this was all blown out of the water when COVID-19 hit. And, HHS, they they oversee Medicare, they oversee Medicaid and Medicare, but, they Medicare again is federally funded nationally, and they decided to waive the restrictions, rightly so. Now, despite the differences of pre-COVID access, they found the GAO found a dramatic increase in telehealth use for both programs. No brainer. Of course it was, because how else were these people going to be able to be seen by their providers unless they could do it remotely? One, patients were too scared to go to their providers. Um, Providers and were kind of flummoxed. I don't know, is that a word? I'm trying to make up a new word. They were being restricted and told what they could and could not do. And so telehealth was, again, an easy way to take care of patients that, one, maybe had possible um, COVID, but they weren't sure. They could go, you could kind of see your provider and say, okay, I have these symptoms. Should I go get tested? Yes, go get in your car and go through the line. Or no, this sounds like an ear infection, or no, this sounds like asthma, or no, this, or what about a diabetic that is having problems, or, again, this was a way for providers to stay in touch with their patients. And so, uh, we know that it was a game changer for the health system. It would never be the same. Okay, let's move on now. Um, there's a link to the GAO's website, and you can see several of their studies, which it's a government accountability organization. And I kind of fell into a rabbit hole reading a lot of their uh, articles and papers that were submitted. As one does when they love this type of work that we do. Now, going on, it said federal legislation continues to expand and extend telehealth services, right? We knew there was no going back. Telehealth is here to stay. It uh, Now that we have pulled away from the pandemic, and it's like saying, oh, I'm going to give you this fancy tool. You love it, but you can't take that away from me now that you've given it to me. This is so much easier with our health system. They've had, what, 3 years to practice with this and uh, make it a mainstream tool between providers and patients. So the key, though, is if it's not going away, who's going to pay for it? Now, we knew Medicaid was already in a lot of states paying for it, but Medicare was not. Now, are they gonna continue to pay for it? That's the main thing we're getting to. Uh, we know that telehealth is here to stay, as I keep saying. So they are expanding and extending telehealth services, especially for rural health, behavioral health, And there's going to be access options for audio only, maybe for Medicare beneficiaries. Again, that for emergent, beyond like emergency services. And this last statement, the administration plan to end the COVID-19 PHE is on May 11th, 2023. That's what's got everybody kind of up in arms. What are we going to do? This is going to end on May 11th, 2023. Uh, Ultimately, we want to know, are they going to pay? Is Medicare going to pay for it? And if they are, um, how much is the provider going to get reimbursed? And what specifics do we need to know? Now, some of those answers I've got for you tonight, some I do not, because they're still in the works, until still tweaking. They haven't made official decisions, and every time they say they have, the rule kind of changes. But I've got links for you to stay on top of it. Now, again, the rural health, if you're not familiar with rural health, they're called RHCs, and you have to be classified as an RHC. And there's federal qualified health centers, FQHCs, and these are all extended into December, the end of 2024. So that is a relief to know. If you're an RHC and an FQHC, probably nothing is going to change in a big way for you. The rural emergency hospitals, again, you have to be qualified for that. And if you're not one already working with them, then you would know if you were, I guess is the way to say that. Uh, they were added to eligibility for Medicare uh, and originating sites for telehealth. I thought what a brilliant opportunity for somebody that was really savvy is to set up a center for telehealth visits for patients, so that if they couldn't get, they didn't have the accessibility in their homes, that they could go to this place where they couldn't get to the all the way out to the clinic system or the hospital, but they could get to this local area. That'd be real smart if somebody really came up with something and then franchise that. Anyway, so the RHEs is going to be allowed for patients to be located in a specific telehealth service area, and the RHEs also need to meet the Health Resources and Service Administration, or the HRSA. Don't we love to put everything into an acronym? The rule classification to bill Medicare. As an original site or originating site. And this kind of goes back to what Stephanie had asked earlier. Uh, but I've got resources for you to look that up. Let's talk about behavioral health, though. So the website stated that Medicare patients, again, we're not worried about right now Medicaid, because they're pretty much covered. We're good there. But with our Medicare patients, they can receive the telehealth services for behavioral health in their homes in any part of the country. And again, we are not really too worried about behavioral health, because that is in the public eye. That is something that's being talked about constantly. And as even pre-pandemic, this was newsworthy. There was already a shift in the care that patients were getting regarding behavioral health. They had been talking about it for 20 years, but it finally started picking up steam, saying, after the Affordable Care Act went in, then they were saying, we need to pay attention to behavioral health. So the in-person visit requirements before a patient is eligible for telehealth behavioral health care services is delayed through December 31st through of 24. Get my cursor back over here. I really want to take a moment to apologize to anybody that is watching and listening that is OCD, because I had all of this over to the left in the corner, and I thought, oh, how boring that looks. Then I'm going to centralize this. And then I looked and I thought, oh my, this is going to drive OCD people insane when they look at this slide, because it's centered, but it's also bulleted. Just sorry about that. Yeah, and I thought about switching it up, and I thought, "No, that gives me a moment to tell people that this could be a problem." And, Sue, I'm not having any troubles on my end seeing, the blurriness or anything. I know a couple people mentioned that, but that's not an issue on my double screens, and I'm seeing the televised off to the side. Uh, what are extensions? There were extensions built in, and it involves the Medicare beneficiaries, first dollar coverage for telehealth services, hospice care, and acute hospital care at home, which the latter I am not as well versed in. I had to go in and do a little bit of research. I would encourage you to do that also, and, we CCO loves to unpack this information, and when we get content and topics that you want us to go over, we love doing that. But I also think there's a fine line with, okay, I can just feed you codes and information, but I can also uh, it, it would be more beneficial for me to let you highlight it, let you become aware of it, and then show you how to look it up and stay on top of it, because again, this stuff changes all the time. So if you're like me that was not at um, didn't understand the acute hospital care at home, I wasn't aware that that was kind of a thing. Well, because it's not around here, offered around where I'm at. Then do some research for yourself. So there are extensions, and they fall under these four criteria. Let's unpack them a little bit. With Medicare beneficiaries, what does that mean? So, the telehealth flexibility that we mentioned before, the waivers are extended, including, this is key, geographic and originating site restrictions. So ultimately, Medicare patients can continue to use the telehealth services in their home, and allowing audio only telehealth, because we've already mentioned this, services through December 31st, 2024. Now, that's Medicare. What we were talking about prior, when we were saying that audio only doesn't count, it doesn't count for risk adjustment. Risk adjustment is another area. And we're not going to delve into that too much. That's a passion of mine. But it when we say it's not allowed, we're not saying that you can't have an audio only visit. You absolutely can. However, the caveat to that is that any diagnoses that are listed for you in an encounter that's a telephone only visit, it is not going to be able to be used and turned in for your RAF score. Okay. Usually you have more visits and there's nuances to that. So you can have, and I'm speaking to you as if you're a Medicare patient. A Medicare patient can have a telephone only visit, and the provider will get reimbursed for it. But when we're tracking risk adjustment, those diagnoses are not allowed to be captured and abstracted from telephone only visit. It has to be a video visit or a face to face visit. So don't get confused there. Now, additionally, there's a list of providers that are eligible to deliver telehealth services, and that's expanded, and Medicare beneficiaries can continue to receive both physical therapy, occupational therapy, speech and language sessions via telehealth. And that goes through December, the end of the year for 2024. So they're telling you that with the end of the PHE, this stuff is all staying in place. All right. And if you're not well versed in some of that, when we start talking about risk adjustment and stuff, then that's when people get confused, and I don't want you to get confused. Teresa Kelly is asking, does this apply to Medicaid um, RA as well? Yes, it does. Uh, uh, Risk adjustment is very, very strict. And so be conscious of that. Now, that does not mean, Teresa, that your provider will not get paid. They will get paid. It's just you can't abstract that diagnosis from them. I will not say your name right. Verlina. She goes, I'm an orthopedic coder. We have many folks who post surgery cannot get into the office. Again, you're right. Isn't telehealth brilliant for them? Pre-pandemic, if they had, done a good job getting that set up, are being seen with our doctor's telehealth modifier 93 audio only or audio and video modifier 95. These people will be able to come in a couple of weeks in person. Also, elderly folks who have bad knees and hips, who are new patients, can also be seen with both just audio. I mean, this the when we first started using telehealth way before the pandemic, um, it just was so underutilized. And this is a perfect example that Verlina is talking about with orthopedics. These patients need to just sit down with their provider and be able to say, everything's going well, but it's very difficult for them to get in, and not really a good idea for them to be traipsing into an office, especially when they live in a rural area, or maybe they don't have a caregiver to get them there, or they don't need to be driving. Period. Either one of them. So, this is kind of a game changer in staying in contact with that patient, and staying up to date with the care that they need, because if there is a problem, then one, it can be addressed right then. Say, no, I really need to see you. Or, no, let me alleviate your fears. This is normal. Or they could even say, let me look, put the video on there, or send me pictures or whatever, and say, no, 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 that's what that incision is supposed to look like. It's really good. All right. Moving on. Uh, Carmen says audio only does not risk adjust. Correct. 100% correct, Carmen. For Medicare or Medicaid. As far as I know, I don't think anything's changed. Now, please double check it, but it's always been that way. It's not new. Martha says, if the visit starts out as a video and converts to a phone call, do we bill video or phone call codes? Our understanding, and Martha, this is a brilliant question. Um, the way we understood it when I was working for Baylor, and even prior to that, is that as long as it started out as video, that was the intent. And as long as that was the way it was initiated and started, that's what you get to do. Okay. But if they never connect via video, but this is a compliance issue. This is something that you want to have everybody on board and a policy in place, and how to document that properly so that there's no legal issues if they were to come back and try to second guess what you were saying. Let's move on. First dollar and hospice, so short, so I put them on the same slide. Patients with high deductible health plans, that is coupled with health savings accounts, may utilize first dollar coverage for telehealth services without first having to meet their minimum deductible. This is also very beneficial to those patients that again work with a high deductible. And for hospice care, telehealth can be used to conduct recertification of eligibility for hospice care through the end of 24. Again, that is so wonderful. I think that was probably needed anyway. And eventually, I think the trend would have gone there, but now, through the pandemic, we have to look on the bright side. Some really good things and beneficial to our patients and patient population happened because of it. Teresa says there was a CMS FAQ back in 2020 that talks about how if video connection was lost and if majority of the ENC was audio phone only, to bill CPT 99441 through 99443. And again, the key here, Teresa is pointing out, is that was um, prior to the pandemic. So again, I don't want to give legal advice or say, even from a compliance standpoint, that yes or no, because that's kind of wishy-washy. How much of the visit? The first 5 minutes, the first 10 minutes? I mean, where does that end? So, if you are in charge, or even if you're not sure, your provider should have that somewhere stated that we agree as a group that this will be our policy, and we're putting it in our compliance notebook. Everybody signed it and agreed, and that this is how we understand the rule based on ABC. And then again, if CMS or HHS or anybody comes in and says, no, that's not right, then you can say, okay, we learned we now understand, and the process starts all over. Put it, have education for everybody, put it all in the compliance notebook, have everybody sign off on it. So what works now, I guess the best way to say it is what works for one clinic system may not be how another clinic system does it, but everybody has to be consistent, because if you're wishy-washy, it it starts smacking fraud and abuse. Okay. Jane says, I think all of it will stop telehealth, but uh, telehealth services still do it. Yeah. Yeah. All right. So we covered both first dollar and hospice. Now, the acute hospital care at home, again, this was out of my wheelhouse a little bit, but that's extended also to the end of 24. They rely on telehealth services for hospitals to furnish inpatient services, including routine services outside the hospital. If this is your realm, just know that what you've been doing through the pandemic, it sounds like you've got till the end of 24. Martha says, will the POS for Medicare after May 11th still be 11 for the office or O2? Martha, I don't know. So I need to have you submit that question, and I'll follow up and find out, unless somebody else knows. I don't know it off the top of my head. That was not in the research that I did for today. Uh, but that's a really excellent question. I should have looked that up. Controlled substances. I thought this was interesting, and I thought this is something you need to be aware of, because it was in the changes that were happening. So the DEA has made two changes, and they say a practitioner can prescribe a controlled substance to a patient using telemedicine, even if the patient isn't at a hospital or clinic registered with the DEA. All right. Now that I thought was very, very interesting. And then qualifying practitioners can prescribe, let's see, buprophene. I'm probably torturing that one, to new and existing patients with opioid use disorders based on telephone evaluation. Again, that is excellent, in that so many of the people that are needing that can't possibly get in. So they have made those two changes. They're very noteworthy. All right, we're getting kind of close to the end here. What are the issues? Now, the GAO also stated this in some of the information that I was reading from them. And the reason I wanted to include this is the thought, if we think ahead, we need to be very cognizant of what changes to expect in the future. So now they've extended everything out to 24. Well, that's not very far away. And are they going to start tweaking and making changes in between now and then? Yeah, they probably will. Or they'll be clarifying stuff. So this is just like an ever evolving behemoth, so I wanted to give you information that you could jot down to say, these are the issues that they're having, and I think we're going to see some changes, or in the future on this, probably in the near future. Access. They stated clearly, and they've been the GAO has done a lot of research and pulling this information together. Not everybody has high speed internet. Yeah, my and I have family members. My mother-in-law, half the time, she can't get her computer to work. Uh, she does have a camera on her computer, but there's all kinds of issues. She struggles with doing simple stuff for her, and that's an issue. What if people are rural? Now, I have to tell you guys, I live in a town of 201 outside of where I grew up. And I grew up in a resort area, so it's, significantly sized. Um, but the town that I live grew up in, that is 8 minutes away, does not have fiber optic, but my little town of 201 does because they got a grant that extended from the other town that is 12 minutes away. So they pulled it in. Now, it who else is gonna have that, right? So 5 miles away, I have family members that cannot get fiber optic, but I can. And so if they live out in the country, they have to do satellite and stuff, and of course the storms, all that messes with that, but they're always having issues. Now, just about everybody has a cell phone now, and you could do telehealth visits via, put it on a little tripod thing and do it that way. But again, not everybody has access to the internet that can, use video, and we've already even tonight, I have high speed, internet, uh, with fiber optic, but I'm hearing people saying, "Oh, the screen's blurry," or this or that, and that's an issue. Providers' ability to conduct private and secure video visits. How many of you guys have gone to your doctor's visit and you can hear everything that's going on in the room next to you? That's not good. My PCP, they just built on another wing to their clinic. And for my last visit, I was, it's like, oh, a nice new room. This is fun. They needed to expand. It's great. I could hear everything that was going on in the room next to me. Now, usually you could hear outside the door. I could hear the providers at the doctor station talking and everything. And like I said, I live in a pretty rural area, but I could hear everything that was going on in the room next door. I could hear all the questions that the provider was asking, and I could hear the answers. And if you live in a small town, I could have probably, if I wanted to, figured out who was next to me because I probably saw them in the waiting room or I'd see them on the way out. So again, private and secure video visits. If it's already an issue in the clinic without it being video, then how are we gonna handle that? Jane says, yeah, interesting professional data. All right. So that access, how is Medicare, Medicaid, how is CMS and HHS going to um, oversee the secureness of private video visits? And then we also have to think about all the AI and can somebody tap into information and while you're live streaming? I don't know. There's just a lot of details. So we're probably going to start seeing some changes in that. Quality of care. Now, again, necessity breeds genius, and the telehealth having already existed pre-pandemic has exploded, and we've learned a lot, and we've knocked off all the cobwebs for the most part. And yet, some of the problems that we see is this isn't going to be perfect for everybody. Not only every patient, but every provider. Certain providers, this isn't going to work for. Diagnoses, it's not going to work for. So, how uh, a provider is not going to be able to diagnose a broken rib because you got to see it. You got to have an X-ray. Now, actually, there are ways to have X-rays done remotely. They can come to your home. Of course, that's got to be available in your area. But this was many years ago. They had home health had the ability to have chest X-rays done. It was a mobile X-ray, and they were able to do all that. It was amazing back then. And so I'm sure that's you know uh, working better. But there are diagnoses that cannot be done via video. It's plain and simple. How is the provider going to look at injuries and determine? Again, they hands-on things where the provider has to touch the patient is not going to work. Physical exams, you're not going to be able to tell neurological deficits in a patient with hand strength. How are you going to do that? You can't have another loved one saying, "Okay, is the left hand and the right hand squeezing equally?" Yeah, I think so. They're just not trying to do that. Now, again, these are what the GAO is said, these are the issues that we have with telehealth. We can't just convert. We can't do as much as we are probably hoping yet. We have to take care of these issues first before uh, we can just sign off and say yes, this is not going to be. There's no reason not to keep everything in place the way it is. Uh, we have to have accountability, and we have to be able to track so that there's no fraud and abuse. How can you just not sign off and say, yeah, I did 15 telehealth visits today? Um, and three of those were a level 5. I don't think so. Prove it. How can you have do a telehealth visit that would be a level 5 uh, diagnoses and not have your hands on that patient or be able to do diagnostic tests and so on and so forth. And so again, these are issues that we know that are going to come up, and changes will come down the pike. Hopefully, I've been able to give you guys some insight as to the PHE. A couple of the questions that came through, I didn't have answers to at the top of uh, um, my brain. So feel free to send in a note and we will get those for you. Now, if you are part of the CCO club, perfect. Just ask there. And I'm hoping that you are, because that'll be the easiest way to answer the question. If you have a topic request that you would like for us to cover, by all means, we want to hear from you. cco.us/topic hyphen request. Our CCO club members always get priority if you have a topic request, and we know who you are. We will pick yours first. The Stephanie, the presentation itself will be up on the how you're viewing it. I see you're looking in LinkedIn, but you can go into the CCO club, and those presentations get transcripts, they get the recording and a PDF of the slide deck. You can have access to all of that. Uh, Easy to find. It's just cco.us/club. Also, I wanted to let you guys know that we have a lot of fun doing this. Word of mouth is how we advertise. So, whatever platform that you're watching us on, whether it's be YouTube, Facebook, LinkedIn, feel free to share this content and let other people know if you found value in what we're offering. We again want to make sure that one, we're doing that and we're having fun doing it. If you guys let me talk, whatever I want to talk about, it'll always be risk adjustment, diagnoses, and ICD concepts, disease process, physiology, anatomy. But uh, I can't have it always my way. So you let us know what you want to talk about, and we'll unpack those for you. And we truly appreciate your sharing our information and knowing that we're here for people so that they can come and ask questions. Uh, we'd really like to increase our YouTube presence. We've been on there for like a decade. We've got over a decade that we've been on there. And so it'd be really great if you subscribe to us. That would be great. We'd like to increase that. This is the links that I told you about. Also, I wanted the prescription, that was more than I could unpack. So this is what was on the cms.gov website. And those links, you could literally just type that in if you wanted, but maybe your providers are wanting to know how to prescribe the controlled substances, if that is a problem. The COVID-19 information page and the specific medications. However, I would say that on this site, the page, I'm sorry, the very first link is where you're going to get the latest and the greatest regarding telehealth and the policies and the updates. I went ahead and downloaded the final ruling, or the whatever Congress had, and it was 1,645 pages. Like, oh my word! Like, wait a minute, I don't want that, and I'm but again, you can go to the top that link, and they will get it for you. Okay, if you so choose to look at it. All right, guys, we appreciate you joining us. Again, don't forget to tell your friends, jump out to our YouTube channel and subscribe. We'd appreciate it. If you are not connected with us on LinkedIn and Facebook, feel free to do that. And don't forget to tell us what you want us to talk about next. We'll see you here, same time next week. All right. Thanks, guys. Bye.
Do you need more medical certification and business training? Learn more at www.cco.us.